I'd like to thank you all for joining us tonight. My name is Frank Phillips. I'm an orthopedic surgeon affiliated with the medical group of the Carolinas, Cherokee Orthopaedics. I've been practicing in Gaffney, South Carolina for about 33 years now. Over the last couple of years, we've become affiliated with the Spartanburg Regional Healthcare System. Great organization. It's brought a lot to our community, and we look forward to continuing this relationship. We're going to spend a few minutes tonight talking about some newer concepts and some old concepts in knee pain. So I hope that y'all can buckle up your chin straps and listen in. If you do have questions, we will have time afterward to answer as many of those as we can. So we're going to start with a little anatomy lesson. Here's a mock-up of the human knee. Three main bones that we really worry about: the femur, which is the thigh bone we see here at the top, the tibia, which is the leg bone at the bottom, and the patella, or the kneecap. The patella glides up and down on the end of the thigh bone. There is a small bone in the leg, the fibula. It's of importance because one of the four main ligaments in the knee does connect to that. The four main ligaments in the knee: the lateral collateral ligament on the outside part of the knee, the medial collateral ligament on the inside part of the knee, two ligaments that crisscross in the center of the knee, the anterior and posterior cruciate ligament. The anterior cruciate ligament is better known by its initials, the dreaded ACL. We always hear about people with ACL injuries. The other important structures in the knee are the meniscus cartilages, the lateral, which is on the outer side of the knee, and the medial meniscus. These act like bushings in the knee, and they help to distribute force across the knee. Also, the other important structure is the articular cartilage, this white that we see here. It's on the end of the thigh bone, on the top of the leg bone. Can't really see it in this mock-up, but it's also on the underside of the patella. It helps create a smooth cushion gliding surface for the joint to function normally. So what are some of the common causes of knee pain? Well, as we talked about just a few minutes ago, injury. Ligament injuries like the ACL, you can also sprain the MCL, LCL, all those ligaments can be injured. And meniscus injuries, you hear about a basketball player getting a torn cartilage, or you're working out in the yard and you squat down and come back up and feel a pop in your knee won't bend or straighten. Good chance that you may have torn a meniscus. Fractures, patella fracture, you walking into the grocery store, trip, land right on your kneecap, sustain a fracture of the patella. One of the more common things that we see are overuse conditions, most commonly patellofemoral pain. Basically, this is kneecap pain. There's a variety of causes that go into who develops kneecap pain, who doesn't. From here, we look into the degenerative conditions, osteoarthritis being the most common degenerative condition. We'll spend a little bit more time talking about that in a few minutes. The inflammatory conditions, one of the more common ones, rheumatoid arthritis. Lots of commercials on TV touting the latest and the greatest. The thing about the inflammatory conditions, these are conditions where the body's immune system is attacking the lining of the joint. Subsequently, you then develop damage in the joint surface, as opposed to the degenerative conditions, which are a primary disease of the joint surface itself. Now, these things rarely exist in a vacuum, and there are multifactorial causes. So what are these multifactorial causes? Well, age. Believe it or not, arthritis is not a disease of aging. Not everybody who is lucky enough to live into their 80s and 90s develops arthritis. In a little bit, when we talk about the demographics of arthritis, you'll see what I mean. There is a predilection for arthritis to occur a little bit more commonly in females than males. As far as ethnicity, you're 1.5 times more likely to develop arthritis if you're an African American as opposed to being a non-Hispanic white. This leads us to have a discussion about other genetic tendencies. We do know that there's somewhere between 7 to 11 genes that have been associated with arthritis. Depending on how many of these genes you carry on your individual chromosomes helps determine what severity of arthritis you may or may not have. Bone density really is more applicable in the osteoporosis world. That's beyond the scope of this discussion. There have been studies that show that estrogen replacement therapy actually is beneficial to help with the inflammatory aspect of knee pain and knee arthritis. Nutrition kind of goes without saying. We get the building blocks for our cartilage and all the other soft tissues from our nutritional sources. Good nutrition means good bone health, good joint health. Obesity, which of course is a huge epidemic in this country, has such a negative effect on knee pain. If you think, when you take a step, you put about 4 times your body weight across your knee. So just a few pounds of difference times the number of steps that you may take in a day can make a big difference fairly quick. Not only because it creates more wear, but it also just creates pain. We talked a little bit earlier about joint injury. Besides the ACL tears, you can actually have damage to the joint surface itself. More joint injury increases the risk of developing arthritis down the road, besides just causing the joint to hurt. Joint deformity, we all see people who are knock-kneed. Our medical term for that is genu valgum or bow-legged. That term is genu varum. When you have those type of conditions, that increases the force on one part of your knee and can create extra wear. Now, sports participation, believe it or not, actually is probably beneficial in the face of a normal joint with no deformity. There are studies that show when you look at runners, the coating on the end of the bone, the articular cartilage, is actually thicker in runners than it is in non-runners. And muscle weakness, it's not just muscle weakness. Muscle weakness causes pain. Muscle weakness has to be addressed in any rehab program, and it's not just a muscle weakness, it's muscle balance. We want to make sure our muscles in the front of our leg are properly balanced for the back of the leg. The muscles on the inner side of the thigh are properly balanced for the outer side of the thigh. Believe it or not, our low back, our entire core, all the way down to our calf muscles, all play a role in how the knee functions and has an impact on the amount of pain you may or may not have. So we're going to kind of concentrate a little bit more on the osteoarthritis from here. When we look at the demographics, if we are just looking at X-rays, now I always tell my patients, I don't treat X-rays, I treat patients. But if we do look at X-rays, and patients, once you get about 45 years, then somewhere between 19 to almost 30% of patients are going to show X-ray evidence of arthritis. However, the important thing, the symptomatic ones, that's about half of that, 10 to 17% at 45 years old. The lifetime risk of developing arthritis is about 40% in males, almost 50% in females. This risk does increase to 60% if your BMI is over 30, which is considered obese. And the incidence, this is important. The incidence does climb until your late 60s. If you can make it to your late 60s and you don't have arthritis, then the chances are pretty good that you're not going to get arthritis. So what is osteoarthritis? So another little schematic of the knee. Once again, here's our femur or thigh bone. Here's the tibia of the leg bone. Nice, shiny, white cartilage here. I liken this to a German superhighway. Now over here is I-85 between Spartanburg and Gaffney. This is an arthritic knee. Potholes, pits, and cracks. And if you've ridden in your car on I-85, you know what it's like trying to walk on a knee that's got all this type of damage in it. The bone spurs do develop, and I'll show you an X-ray here. Here's a normal looking knee. It says here normal joint space. This really isn't space. This is the articular cartilage. It doesn't show up on an X-ray. Now, as the joint wears out and the cartilage starts to thin out, this space thins out, eventually getting to what we see as bone-on-bone arthritis. Along the edges here, we can see these little bone spurs. Bone spurs are not the cause of pain. They're a result of the cause of pain. It's the body's weak attempt to try to repair the damage that the arthritis has created. So what are some of the non-surgical treatments for knee arthritis? Our national organization, the American Academy of Orthopaedic Surgeons, has come up with a wonderful guide for, it's called Ortho Guidelines, and we have it for a whole host of diseases. And all of this is evidence-based medicine. We look and we try to find the science. You know, through the years, we in medicine are really working hard to make any of our treatment decision based on strong science. So there is strong evidence that rehab works. Now, this doesn't mean you have to go to physical therapy 3 days a week or anything like that, but it is doing rehab. We talked about the muscle weakness. There are specific exercises to help restore the muscle balance. Education. Learn about your condition, whether it's rheumatoid arthritis or whether it's osteoarthritis, whether it's just patellofemoral pain. Education. And most of the time in our office, we have plenty of educational materials that can help with that. Wellness activity. So with wellness activity, pick the one you like, whether it's walking. I'm lucky enough to live close to the Cottonwood Trail. I love walking on the Cottonwood Trail. It's great for the mind and the body. Yoga, meditation, Tai Chi, any of these sort of things, whatever suits your fancy, it does help. There's plenty of literature that supports the use of NSAIDs, not just oral NSAIDs, but topical NSAIDs. There's a few that are on the market now. Topical NSAIDs, especially if you have just one joint here or one joint there that hurts, probably works as well as oral NSAIDs and has a better safety profile. It's absorbed nowhere near in the body like a pill is. And then weight loss, we talked about the 4 pounds for every pound. So that's always one of the steps in our treatment plans. Now, surprisingly, and traditionally through the years, there are a lot of other things that we have been using, and I'm sure many of you out there have read about these or experienced some of these. The evidence, when we look at good critical science, the evidence for the use of Tylenol is really somewhat inconclusive. Opioids, now the guidelines that I'm referencing here are actually from 2013. Since then, of course, we know that the opioid crisis has really taken off. So when our next guidelines come out, I don't think we'll be seeing opioids as any sort of non-surgical treatment, except in patients who are unable to consider surgery. Corticosteroid injections. So many people have cortisone shots, and we use it. It's part of our treatment armamentarium. But surprisingly, the evidence is somewhat inconclusive. You can find a study that can support either position that you want. Then there are the biologic injections. Two main types of biologic injections. One is platelet-rich plasma. So the platelets are some of the clotting elements that are in your blood. We have a technique where we can draw blood out of your arm, spin it down with a centrifuge. There is a layer in there, we call it the buffy coat, that has platelets in it. Platelets not only have this ability to help with clotting, but they have a lot of healing factors as well. There's been many studies, several really well-designed European studies that show that this probably does help with knee pain. Contrary to what we were hoping that it would help build cartilage, it doesn't really do that. So it's more of a pain adjunct. Probably works as well, if not better, than the corticosteroid injections. And some recent studies have shown that at 6 months, patients are getting better pain relief than they do with cortisone shots. Now, stem cells, all you have to do, open up the newspaper, turn on the TV, open up a magazine. Lots of misinformation and disinformation about stem cells. The commercial use of stem cells has skyrocketed. The numbers are just phenomenal. Unfortunately, they don't really work. We don't really have good evidence that shows that stem cells in their current way that they're being delivered are of any use for knee arthritis. There are several uses of stem cells outside the orthopedic world. There's a lot of research being done, and I'm hoping that maybe 5 years from now, I can come back to you and say, hey, here's what is going to work. There's another technology that we're really excited about. It's been around for a few years. It's called cryoanalgesia. And with this, basically, we go in using a liquid nitrogen probe, and we can freeze the nerves that are around the knee. There's several nerves that help supply the feeling to the knee. We can go in, freeze these nerves, and get at least temporary pain relief, somewhere 4 to 6 months. So it can be used not only in the non-surgical treatment, but it can also be used as a surgical adjunct to help with post-operative pain. We feel like we're right around the corner with getting this technology available to us. Now, of interest, there is very strong evidence that does not support the use of glucosamine and chondroitin sulfate. These are two of the building blocks of the articular cartilage. When you critically look at the literature with good, what we call double-blinded studies, people taking placebo, people taking a combination of these, there's no difference in how they do. I have a lot of patients that still take it. My own feeling is there's really no harm other than the harm to your wallet. Another treatment that has been around now for about 25 years, viscosupplementation. All joints in the body have a thin fluid layer. The main element in this is hyaluronic acid. It helps with the cushioning and the gliding of the knee. Back in the late 90s, we came up with a technique to supplement this fluid. We feel like arthritic joint fluid is not thick like it's supposed to be. I kind of liken it more to normal joint fluid is like motor oil. Arthritic joint fluid is more like transmission fluid. So there are now about 8 or 9 of these different preparations out there. Unfortunately, the literature does not really show, once again, that it works. I do have a subgroup of patients that I do feel that it's beneficial for. If you come to me with moderate arthritis, not a lot of mechanical symptoms, mainly pain, not a lot of swelling, those are the patients that, in my experience, do get some relief with the viscosupplementation. So hopefully that's going to take care of the bulk of our patients, and we don't have to go to the next slide, which is the surgical treatment of knee arthritis. When we look at surgical treatment of knee arthritis, there's about 4 options. Each may or may not have its place. When we look at our guidelines for the non-arthroplasty, that's a non-replacement treatment of knee arthritis, arthroscopy, and I'll show you some pictures of that in just a minute, arthroscopy really isn't recommended. There was a landmark study done back in the early 90s where they took a group of veterans in Houston. Half of them they actually did arthroscopy on, going in, cleaning out their knee. Half of them they just made the incisions, and those patient populations did absolutely no different. There's been some other studies that have kind of replicated those results. Osteotomy, I'll show you some pictures of that in a minute. That's recommended only for younger and active patients who have malalignment. In other words, the bones are not lined up right. You try to correct the alignment, and this can many times at least help put off knee replacement for a long time. And then there's partial knee replacements and total knee replacements. So here's a couple of photos of arthroscopy. On this side here, we're looking at, this is the femur, which is the thigh bone. This is the tibia down here, which is a leg bone. Beautiful, pristine surfaces, shiny as can be. This structure here is a meniscus. This is the medial meniscus, completely normal looking. You can see how smooth that is. Over here on the right side of the screen is an arthritic knee. This yellow here is actually bare bone. So this coating that we see here has basically peeled off. Same thing. So here's the femur, down here on the tibia, same thing. Now, surprisingly, the meniscus here looks pretty darn good. This is a knee that does not benefit from arthroscopy. Now, if we looked in this knee and saw a big tear in this meniscus, and the patient was describing a twist this way and my knee pops and catches and I can't straighten it, that patient may benefit from arthroscopy. But for a knee like this, arthroscopy really isn't recommended. We mentioned osteotomy for the younger, more active patients with malalignment. This here is a knee that is genuvarum, bow-legged. This is the inside part of the knee. This is the outer part of the knee. Now, this is a weight-bearing X-ray. The patient is standing up when this X-ray is done. As you can see, completely collapses on the inside. In an osteotomy, we literally make a saw cut through the bone, and then we have a method where we can swing the bone out, and then we come back in and put plates and screws and backfill it with some bone graft. That's what this fluffy stuff is. So here's weight-bearing X-ray before the surgery. Here's weight-bearing X-ray after the surgery. What we basically do is transfer the force that was on the inside, shifting it more toward the center of the knee where it's supposed to be. Very strict indications. If you use very strict indications for this, it can definitely be a procedure that is of great benefit. Next on our list was partial knee replacement. So typically for a partial knee replacement, isolated single compartment disease. Our knee is 3 compartments: the medial compartment, the inside part, the lateral compartment, which is the outside part, and the patellofemoral compartment up underneath the kneecap. Most commonly, partial knee replacement is mainly for the medial compartment or the patellofemoral compartment. It only removes the damaged parts, doesn't remove all of the parts of the knee. The advantages, because we're not removing all the parts, there's a little bit quicker recovery. Incisions are a little bit smaller. There's less pain, once again, because we don't have to cut through all of the bone. And it has a more natural feel because we're keeping all of our own natural ligaments. Now, the big disadvantages is a little bit less predictable as far as overall pain relief, and there's a little bit greater chance that you'll need more surgery, as the failure rate of these is a little bit higher than with total knee replacement. So here's a schematic of a partial knee replacement. This, once again, femur here, tibia here, and here's a partial knee replacement in place. Here's the 2 main components. This is a little, almost like a little metal glide that sits on the end of the femur. This metal tray that sits on the top of the tibia with a plastic spacer in between. And here's an X-ray of it, bone on the inside part of the knee. Here's where we see the replaced parts. All this bright white that we see is metal. You can't see that plastic spacer, but there is a plastic spacer in between. And here's an example of a patellofemoral replacement. This is dreadful patellofemoral disease. This is bone on bone on bone. About as bad as I've seen. These are not my patients. These are sample X-rays, but I have seen patients with this degree of disease. And in this one, basically all we're doing is going in and carving out on the end of the thigh bone where the kneecap lives. We put in, once again, the bright white is a metal, it's the metal that replaces the coating. And you can't really see it here, but there's a little plastic button that sits on the underside of the kneecap to help restore the patellofemoral joint. So then that leads us to total knee replacement. As the name implies, in total knee replacement, we do remove all the parts of the knee and replace them with metal and plastic components. Very popular, over 600,000 are done annually in the US. It's popular because there is a high success rate and a high satisfaction level. Not everybody gets great results, but overall it's a very high success rate. The important thing to remember is 0.5 to 1% wear out every year. I'm always asked, well, how long is it going to last? And the answer is, well, you got to look at the statistics. And the statistics show that 0.5 to 1% wear out every year. What does that mean? That means knees put in today, if you look at them 20 years down the road, 80 to 90% are still going to be functioning. That's not too bad. So here's a schematic of the total knee replacement. Once again, here's our femur, here's our tibia. We cut the femur and we use guides to make sure that these are precision cut. And there's all sorts of techniques using robots, using computer guidance, using handheld guides. Right now, no studies show whether that robotic cuts are any better as far as longevity than standard cuts. Femur here, metal piece on the end of the thigh bone, metal piece on the top of the leg bone, plastic spacer in between, plastic spacer on the underside of the kneecap. Disassembled, assembled. Now, we do take out the two cruciate ligaments, the two ligaments in the center. We save the ligaments on the side, and this gives us our stability for side-to-side movement. And here's an X-ray of a knee replacement. Significant disease, once again, primarily on the inside, a little bit of disease on the outside, followed by the bright white showing where all the metal components are. Once again, there is a spacer in between. Now, total knee replacement is not without risk. What are the major risks that we see? Stiffness. 1 to 3% of the times we do see stiffness. If your knee is stiff before surgery, the likelihood of stiffness after surgery is a little bit higher. Through the years, we've tried all sorts of techniques to help mitigate this and lessen it, but no matter which techniques are used, pretty much that number remains about 1 to 3%. Infection, about 1% of knees are going to get infected after the surgery. Infection after knee replacement is a devastating complication. We do everything we can to prevent that. Appropriate antibiotic use, appropriate hygiene. We continue, and our institution has a tremendous program to help improve our outcomes. And this is in place in all of our institutions across the system. DVT, deep vein thrombosis, blood clots. Luckily, this is really not all that common in modern medicine. When we first started doing joint replacements back in the 60s, 50s, 60s, 70s, they put patients in bed for somewhere 2 to 6 weeks. All of them got blood clots. Now that, we do outpatient knee replacement now. You can come in that morning, you're home that evening, and we get our patients moving. When you get your surgery in the morning, you will be out of bed at lunchtime, and that seems to be as important as any other medication that we can give to help prevent blood clots. Prosthetic failure, we talked about that earlier, 0.5 to 1% every year. You see the lawyer ads on TV for certain types. We do see catastrophic failure with poor designs, but luckily those are few and far between, and we find that out and those designs go away. Unfortunately, 10 to 15% of patients are going to continue to have pain. Some of the predisposing risk factors, if you have conditions like fibromyalgia or chronic pain, higher chance that you're going to have pain afterwards. If you have preoperatively used opioids, those patients tend to have persistent pain. Patients with untreated depression tend to have persistent pain. And then, of course, as with any surgery, medical complications, all of these are extremely rare. MIs, heart attacks, breathing problems, including pneumonia. Once again, as far as that's concerned, we have our patients up and moving, always have them using our little breathing devices to help decrease that risk. And there are instances of acute kidney injury. Those patients, most of those patients typically recover. That's a whiz-bang quick overview of knee pain and the treatments of knee arthritis. At this time, I'll be happy to answer any questions.
Thank you, Dr. Phillips. That's wonderful information. We really appreciate you being here with us today. We do have a couple questions. The first one, my knees make a popping and grinding noise, but I am not experiencing any pain. Is this normal? When should I seek medical advice?
So that's not necessarily abnormal. That's a sensation that's called crepitus. A lot of times, depending on the situation of when that happens, it's similar to your neck, to your knuckles popping. It's a bigger joint, bigger noise. When crepitus is associated with pain, as you're feeling that crepitus and that crunch and it hurts, or if it's associated with swelling or locking or catching or giving way, that's when you should seek attention. Medical attention.
Wonderful. Thank you for that. Are there any exercises that help alleviate knee pain? Are there any I should avoid completely?
So there are a whole host of exercises. Our national organization has a wonderful informational website. It's called orthoinfo.org. And on that website, you can find a lot of self-directed exercises. And these are the ones we hand out a lot of times in our office. I would encourage patients to look at those. Basically, straight leg raise, laying on your back, raising your leg up in the air, things like this. The one exercise I always try to have patients avoid is a knee extension exercise. Back when we were all in high school, you go in the gym trying to get the big quads, making your thighs look really good. You get on the machine, put a strap of weight around your ankle and try to straighten out against resistance. That is a horrible, horrible exercise, especially if you have any kind of kneecap problem. And your knees will let you know really quick that you shouldn't be doing that.
Wonderful. Thanks so much. We've had another question to come in. Why is it so important to walk so soon after knee surgery?
Well, my partner, I learned a quote from him several years ago when he first started with me. Motion is lotion. Okay, it's important to get up and get moving. It helps, like we talked about, decrease the risk of blood clots, help with your ventilation. And it's important for your brain to see, hey, look, I can get up, I can move.
Super. We have another one. I have a bulge and a feeling of tightness behind my knee, especially when I extend my leg. What's the cause of this?
So that's a condition. It's called a Baker's cyst. And basically, a Baker's cyst, it's a weak spot in the lining on the back side of your knee joint. Most of the time, especially in adults, the Baker's cyst is associated with something going on inside the knee, whether it's arthritis inside the knee, whether it's a little torn cartilage, anything that would cause your knee to swell. And because you have this weak spot in the lining, instead of the knee swelling all the way around, it finds this localized area to kind of swell out the back. They're very, very common. There is another type of Baker's cyst that we see in the pediatric and juvenile population. I, in fact, was diagnosed with a Baker's cyst when I was in 8th grade and have been carrying it with me ever since. We don't really treat the Baker's cyst in that we don't go and take out the Baker's cyst. If you can address the problem that's causing the Baker's cyst, most of the time the Baker's cyst will tend to go away.
Super, thanks so much. You mentioned outpatient knee replacement surgery. What are your thoughts on the same-day outpatient knee replacement surgery?
Well, if you had asked me about 7 years ago, I would have said, what in the world are you talking about? But after, over 30 years in this business, you learn that there are things that we can make better. And outpatient knee replacement, the literature supports it, and the literature supports it that it is absolutely the way to go with the right patient. Some patients just, they probably need to be in the hospital. Younger, healthier people, there is really no reason that you shouldn't consider outpatient knee replacement.
Thank you. I had another question to come in. My 11-year-old is very active and having intermittent pain with some popping. Should we seek medical attention?
Given the fact that you're having pain and the popping like that, it's never a bad idea to seek medical attention. At least get the advice of an orthopedist.
Excellent. We've had another question to come in. What can I do to help if I have stiffness in my knee?
Motion is lotion. No, yeah, so we try medications, over-the-counter anti-inflammatories like the ibuprofens and the naproxens. Heat is a great modality. And here's the thing, heat and ice. The simple way to think about it is you warm up and you cool down. So to help, you use heat before you're trying to do an activity. Even some of the muscle rubs, they help a little bit just because of that feeling of heat. Okay, range of motion exercises. If you've got access to water therapy or a swimming pool in your backyard, that's a great activity because it helps to unload your joints. If you are dedicated enough to take the time to sit down, do all of your exercises, warm up beforehand, do your exercises, ice down afterwards.
Excellent. That's some great advice. All right, that was our last question. Thank you so much for joining us today. We really appreciate it.
Well, it's been my pleasure, and hopefully I've been able to relay a little information to all of y'all.